La
Should I
grabación.
share my screen?
Okay, just wait. So I'm
Okay.
going to admit all the people.
Okay.
Wait. So, okay. They are getting in. Okay. Okay, Jesus, I think you can start. Vanessa.
Okay, thank you. So I'm going to be switching back and forth, Arsham, a little bit. So, bienvenidos a todos. Gracias por estar con nosotros hoy con el doctor Arsham Sheybani. Vamos a hacer la presentación en español y en inglés. Vamos a dar la oportunidad de que si tienen preguntas y las quieren hacer en español, por favor, abran su video. Aprovechen la oportunidad de que tenemos al doctor Sheybani con nosotros. Súper buena persona. Great friend, easy to work with, easy to connect with. So, aprovechen esa oportunidad para hacer todas las preguntas, todas las dudas, que muchísimas veces ustedes me las hacen directamente a mí y yo no soy la mejor persona para respondérsela. Entonces, aprovechen que si cuál es el mejor lente, cuál es la mejor posición, que si me está costando hacer esto. Este es el momento, esta es la oportunidad. Arsham es un excelente profesor, maestro, mentor, amigo. Entonces, me pareció cuando Jesús me comentó que quería invitar a Arsham, es uno de los temas que yo he visto presentar en las conferencias, en grandes congresos y también con los residentes. Y es una conferencia magistral, en mi opinión, para aprender ese tipo de detalles. Jesús.
Muchísimas gracias, Vanessa. Muchísimas gracias. Bueno, bienvenidos todos nuevamente al espacio del webinar del Grupo Venezolano de Glaucoma, donde solemos mes a mes tratar de desarrollar algún tema de interés para la comunidad. Bueno, yo me encuentro muy feliz, gracias a la intersección de la doctora Vera, por la invitación, y hoy tenemos presente al doctor Arsham Sheybani, bueno, un destacadísimo oftalmólogo, un talento joven de la oftalmología mundial. Y bueno, hoy vamos a tener, Dr. Sheybani, welcome to the Venezuela Glaucoma Group webinar. On behalf of the Venezuelan Glaucoma Group, it's a true honor to welcome you to this webinar, a space created with the goal of advancing knowledge and clinical practice in the field of glaucoma. Bienvenidos todos. Bueno, a continuación voy a proceder a hacer un breve resumen de el extenso currículo del doctor. El doctor Sheybani es médico asociado al Servicio de Medicina de la Universidad de Washington y también presta sus servicios como asesor en la Universidad del Estado de Utah. El doctor Sheybani, bueno, es un gran investigador y conferencista a nivel internacional. Realmente el currículo abarca prácticamente 8 páginas, de lo cual voy a hacer un breve resumen. El doctor es un líder renombrado en la cirugía mínimamente invasiva de glaucoma. Es un líder que ha estado al cargo de investigaciones tales como el Gold Standard Pathway Study, y tiene la autoridad de más de 50 publicaciones peer review. Ha colaborado y es líder en la innovación oftalmológica en compañías incluyendo Allergan, Alcon y Glaucos. Su trabajo incluye la parte de educador global y pionero en el desarrollo de nuevas técnicas que han hecho un impacto significativo en la oftalmología moderna. Él también es autor y contribuyente en muchos aspectos de los libros de oftalmología y ha recibido múltiples honores por sus impresionantes contribuciones, incluyendo presentaciones extraordinarias en Oscars y en la American Glaucoma Society. Su impacto se extiende a los medios de educación, a las técnicas, desarrollo de nuevas técnicas quirúrgicas y avances en biomarcadores de investigación en glaucoma. Dr. Sheybani, welcome to the Venezuelan Glaucoma Group. Bueno, Whenever you want. Welcome again.
Thank you so much. Vanessa knows I don't speak Spanish. My son does understand her when she's speaking Spanish, but it's really nice to be here. And Vanessa is a very, very close friend. So if she asks me to do anything, I will always say yes. So that's just how it is. I'm going to talk a little bit about MIGS surgeries and angle surgeries. And you may notice that some of the devices that we discuss are going to be things that might not be accessible in every country. But then I use those as a way to kind of teach how MIGS surgery should be done. But we'll also talk about some pretty cost-effective ways to also do angle procedures, and they can be really good ways to learn how to do them. Vanessa, is it showing up for everybody, the PowerPoint slides, hopefully?
Yeah, I see it on my end.
Perfect. Okay. Is it notes view or is it everything's okay?
No, it's presentation mode.
Perfect. Oh, presentation mode. So I can go back to I'll set it just so we have like the entire PowerPoint so you can visually see it. Okay, there we go. Okay, so I'm going to share screen here and we will start. Good. Okay, see it okay?
Yeah.
Okay, perfect. Okay.
Yes.
So the disclosures, as were discussed, I do work with some of the companies that are involved in MIGS, and some of these things we will go over. But what I really like to point out, and I show the slide when we teach angle procedures, is you really have to understand gonioscopy before you start with angle procedures. And this was a patient that was sent to us for progression of vision loss and glaucoma, but had relatively normal pressures. And the surgeon had already done SLT. And when you look here, the trabecular meshwork, it looks like this is the trabecular meshwork because it's very pigmented. But when you use gonioscopy and put a little pressure, you actually see that's not the trabecular meshwork. This is the trabecular meshwork. So it was an angle closure patient. And the reason why this is important is because when we start doing MIGS procedures and angle procedures, doing them in the wrong area can either not work or you can have very significant bleeding if you are in the ciliary body band. So understanding gonioscopy is very important. One of the ways to determine where the trabecular meshwork is compared to a Sampolisi line is the trabecular meshwork, the pigmentation is almost like a paintbrush sweeping across the trabecular meshwork. Sampolisi's line, you'll see generally dots, like dots of pigmentation, very fine dots. And that's how you can tell a difference. And we'll talk about some ways that you can really view the angle. But if you push too hard with your gonioscopy, then you start to have an abnormal view. And this is very important in the operating room. You want to be able to have a very light touch so you can see the anatomy without causing these folds in the cornea. I like to show this video because if you look, the pigmentation line here is where people would think is the trabecular meshwork. Again, that's the Sampolisi's line, but look at the red line right below it. And that's where the true trabecular meshwork is. And this is why it's important to be able to do gonioscopy and understand the layers, but this pigmentation is not trabecular meshwork. This area is trabecular meshwork. And so one of the ways in the operating room to really see where the trabecular meshwork is lower the pressure, and you will generally see blood coming back, and that will show you where the trabecular meshwork is. This is a demonstration of how the view really matters based on how you turn the head. Right now, the gonioscopy prism is placed on the eye, and we are only rotating the head of the patient, and we're not rotating the scope. So as we rotate the head of the patient, you see that you're still not able to see a great view yet. Now we're going to rotate the microscope as well. So both the patient's head is turned and the microscope is turned. And now you get a very clear view of the trabecular meshwork. But look what happens when the patient looks to the surgeon. The view goes away. That's the trabecular meshwork. This is the scleral spur, ciliary body band. So trabecular meshwork, scleral spur, ciliary body band. If the patient looks too close toward you, all of those layers blend together. And one of the most important things I think for visualizing the angle is make sure that you have the patient look away from you enough. Generally, if you don't see a good view, it's because you have not rotated the head or had the patient look away from you enough. And again, like as we watch the video, as the patient turns to the surgeon, the tissues start to line up like they are all in one plane. And it's very difficult to see the difference between the tissues. But when they look away, and that's what we call en face, really in line with our view, when they look away, you can really see the proper trabecular meshwork and the anatomy. So the MIGS surgeries, very quickly, they are through a clear cornea approach generally. The advantages are they're minimal in their trauma and they don't change the refraction. So like trabeculectomy and even sometimes tube shunt can change the refraction of the patient. These generally do not do that. They don't have to be like getting you down to a pressure of 8. This is not what it's for. This is for generally earlier disease or patients that are relatively
Arsham,
new. Yes.
you stopped sharing, and I think we see your desktop now, or something else happened.
Wow, weird. Okay, let me try it again.
Is that your desktop with all the hearts?
Oh, the hearts.
Yeah.
Here. Let me see if I can
Okay,
get.
now we see it. Okay, there you go.
Is it good?
Yes.
Okay, perfect. But the efficacy is not something that's going to be severe, but generally they have a good safety profile, and the recovery for the patient is very similar to just cataract surgery. It doesn't add a lot more inflammation or even bleeding if it's done right. And years ago, there was a publication on the collector channels, and Carl Asher noticed that as he was looking at the limbus, so this is the limbus, this is the cornea, and then this is the sclera. As he was looking, this black area that he's drawn is actually a vein. But sometimes he would see a red blood vessel go into this very clear space. And he would follow this clear space and it would make a loop back near the limbus. And he guessed, and he guessed correctly, that this was an aqueous vein or a collector channel. So the collector channels move the aqueous to these aqueous veins that then join the episcleral veins. And this is something that we can see even in the operating room. There's about 1 to 6 of these visible. You can see them at the slit lamp if you really pay attention and you push against the eye. Most of them are in the infranasal angle. Now, that's on average. I do think if you work in the nasal angle, that gives you the best chance at accessing more of these veins. And we don't know if they become smaller because the trabecular meshwork is diseased, or they become smaller and then cause the pressure to elevate. But when you start to look at some of the data between SLT and even early surgery for patients with early glaucoma, I think many of us do agree that the earlier you address keeping flow going through that system, probably the better that will be for the patient. And if you, yes.
Sorry, sorry to interrupt. There's a chat going because I think some participants, I see your presentation, but some participants don't see it. Okay, so everybody's chiming in. Some people say I see it. Some people say I don't see it. So let's make sure, guys, sometimes, let me switch. A veces hay que moverse en Zoom en las diferentes pantallas y hay que hacer swipe to the right or to the left para que puedan ver la presentación. Prueba eso, Marcos, a ver si te funciona.
Vanessa, ya lo veo nuevamente.
Ok, ¿y Marcos? Marcos es el que tenía problema.
Marco la veo otra vez ya la vio.
Okay, we're good. Sorry, go ahead.
You see it? Okay, no, thank you. Let me know.
Arsham.
Thank you. And as we start looking at this, really, it's very interesting when you start doing surgery in the angle. And I'm going to show you some pictures of how some of the collector channels can be actually very large and carry a lot of volume of fluid through them. This is a Wexel sponge on top of an aqueous vessel or a collector channel. And this is in the operating room. When we put pressure on this sponge against this vessel, you start to see a little bit of blood backing up into this system. When we relieve the pressure, then the blood pushed out by the aqueous flows this way. If I lower the pressure in the eye, and this is before we've done any surgery, if I just lower the pressure a little bit in the eye, then the blood starts to come back into these vessels. And it's very subtle. Sometimes it's very difficult to notice. But look what happens if I put a stent in this zone. And look, this is the curve that you see that is typical of an aqueous vein. So now we have a stent here. We lower the eye pressure. This allows a lot of blood to come back into the anterior chamber. Now we raise the pressure and the fluid flows from the stent into the collector channel. And raise it for another second, and look how clear this is. Large vessel that is now clear, moving aqueous or fluid through that system. And this is why we try to address the disease early if we can, because generally these veins are bigger. They can move more fluid if we do it earlier in the disease. And this was an old generation of an eye stent, but it's a nice representation of what happened. So first, we put a little pressure, and we have the pressure in the eye raised up. Then we use a Wexel to see where the collector channels are. You can see as we put pressure down, you would get clearing, which tells you this area is moving fluid. So now we turn the patient's head away from us. We turn the eye away from us. Look at the area. It has a lot of pigmentation in that region. So that generally tells you that probably is more flow going through there. The pigment goes through there. And that's probably where our collector channel is. And this is the first generation of the eye stent years ago. But I like this video because it shows you, even though you think you're in the right place, you still might not be in the right place. And this is when people talk about how procedures don't work. I think some of it is it's just not placed in the right area. It's not in the Schlemm's canal. So we feel like this is superficial. It's not fully in Schlemm's canal. So with micrograspers, we try to adjust it. I'm still not seeing blood flow. It still doesn't seem like it's perfectly positioned in the canal. So now what we'll do is we will move it over to the right and try to go a little deeper into the canal. So grabbing the stent with the micrograsper, we're going to now go deeper into the canal. And look at what happens now. We start to see a little bit of blood coming back in. Now I know I have a connection to the canal. And look what happens to that same vessel that we saw earlier when we raise the pressure. So the irrigation is in the eye. We're going to raise the pressure, and look at what happens here as the fluid moves through this collector channel there. And that's what the stents do, is they help bypass some of the resistance in the trabecular meshwork and give more direct access to the collector channels. But you have to be careful. And this even happens in goniotomy, where sometimes we think we're removing tissue and we remove the trabecular meshwork, but we're not removing all of the trabecular meshwork. This is the iris. This is the trabecular meshwork, these three colors, green, red, and blue. And this is Schlemm's canal. If you look at trabecular meshwork, it's not just one piece of tissue. There is the uveal portion, the corneal scleral portion, and the juxtacanalicular portion that we all know. And in fact, believe it or not, sometimes you can just remove a layer of the trabecular meshwork or place a stent in just a layer, and you're not fully inside Schlemm's canal, which means that then it won't work. And this is an example of what I'm talking about. This is the hydrous stent. And what you'll see here is as we place the stent in the angle, there's still some tissue in front of us. So it's going behind something, but it's not fully in the canal. It looks too transparent. You can see it too easily. So now we're going to push in a little bit harder and try to pierce through the trabecular meshwork. And when we place the stent the second time, you will see that you don't see the stent as easily. Even though this patient has very little pigmentation in the trabecular meshwork, the stent is now deeper. This is probably now finally in Schlemm's canal, where the one before was probably inside the trabecular meshwork. And look at the picture. This is the first placement of the stent. You still have tissue in front of the stent. So the stent is behind something. But if you look at that versus this is a very different appearance. This is fully in the canal. And one of the most important things, even with goniotomy, it's not just stenting, is making sure that you've really removed the trabecular meshwork. And how do you know that you have? You will immediately see blood coming into the anterior chamber. If you don't see that, but you just see blood in the trabecular meshwork or behind it in Schlemm's canal, that tells you probably haven't removed all of the trabecular meshwork. So we do use a bent needle to do the goniotomy. And this is a 25 gauge hypodermic needle. It has to be at least 5/8 inch. You can use a needle driver to bend it, but it's the same type of principle. Now this is sharp. So compared to like Scion and KDB, it can be sharper. You do not want to push too hard against the back wall. But if you do it right and it's on FOSS, you still can remove trabecular meshwork. And you see this piece of trabecular meshwork that we've removed. And if you look here, how to actually really create the bend, I don't like 90 degrees. I use a needle driver and I bend it around like 75 to 80 degrees. And then sometimes give it one additional curve to where it's round in the back. And so it doesn't scrape off the back wall. That is kind of the ideal way to do this. And it's 25 gauge or 27 gauge, but the length of the needle has to be, and I'm going to say it in English system, 5/8 inch. So 5-8 inch length. Otherwise it's too short. 1/2 inch is too short for some eyes. And when you do the procedure, this is what we're looking for. We're looking for areas where the collector channels now show reflux back into the eye. So as we're going across the trabecular meshwork, we're now excising it. And remember, this is a good view. It's on FOSS. If I don't see the trabecular meshwork like this, I have to turn the head more. But you'll see focal areas of blood coming back. And pay attention to how this blood looks. It's slow. It's venous. It's focal. There are a few areas, and in this video, I think there's 3 areas where the blood starts to come back. You see here, here, and here. If you see a sudden gush of blood, large blood coming back at you, you're probably in the ciliary body band, and you've hit an artery, which bleeds very differently than the aqueous veins. This is the slow reflux bleeding that we're looking for. If I'm doing goniotomy and all of a sudden, boom, I get high bleeding very quickly, I'm probably too low. I need to move up higher to actually get the trabecular meshwork. So that's simple goniotomy for around 100, 120 degrees. The other one is gonioscopy-assisted transluminal trabeculotomy, or GAT, which you're familiar with. This now uses a suture and is trying to open up trabecular meshwork for 360 degrees or 200 degrees, depending on how you do it. There is data behind this. It works even in patients that have had prior failed glaucoma surgery, like trabeculectomy and tube shunt surgery. My personal belief is if patients have been medicated for years, like 5, 8 years, 10 years, the longer they've been on medication, the less response you will get from doing angle procedures. And I don't really base it off of the severity of the disease. I can have a very severe glaucomatous field loss patient come to me but they've never been treated. It was first diagnosis. The angle will probably work better in that patient compared to even someone with ocular hypertension, but medicated for 15 years. Those are two very different patients. And so how long they've been on medication is how I decide, do I have confidence the angle will work or not? And the less time they have been treated with medicine, the more confident I am that at least an angle procedure can help. So we use a 5-0 Prolene suture. You can use low temp or hot temp cautery to make a small bulb. It's about 30% larger than the suture. The simple way to do it is an 18 gauge or a 19 gauge needle and make a small incision in the trabecular meshwork. This was a patient with uveitis, young patient in their 30s that had uveitis and steroid response, but needs chronic steroids. And you can also use the bang technique that we talked about to make a small goniotomy. After you make a small goniotomy, we then introduce the suture through a paracentesis. When we introduce it, any retina forceps or micro forceps can be used to now place this suture inside Schlemm's canal. And usually it takes about 30 to 40 small pushes to get this 360 degrees. Some patients, it gets stuck and you can't go 360 degrees. But if you can get it all the way around, then you're going to use microforceps to grab that end and pull on both ends of the suture. So as you pull, it cuts the trabecular meshwork. Now, it doesn't remove it like a KDB or a Scion, but it does make an opening or a cut into it. And this patient, I can tell you, for 7 years, had great pressure control. Just last year, finally came in, the pressures were going up, and we had to do a tube shunt. But he went from his 30s to now in his early 40s before he needed a tube shunt surgery for uveitic glaucoma. So many, many years of efficacy here with this procedure. Now, how much do you actually have to treat? Well, if you look at this graph, this is showing what's called the fluid wave. So how many clock hours we see blanching or whitening of the episcleral vessels. And around 4 to 6 clock hours is about the maximum area that you need to treat to really get your full efficacy. And even Chandler and Grant in one of their old textbooks said that after about 6 clock hours or half of the Schlemm's canal being open, you're not going to get more pressure lowering opening more. And what we have found is the more you try to open, so 360 degrees just has a higher risk of bleeding. The pressures probably don't matter all that much. But it's important to know, if you're really trying to get good efficacy, most of the data now says treat at least 180 to 200 degrees to get your most efficacy. And there are devices. So this has a light. We can now see where the catheter is going. And I do like this in patients because sometimes with the suture gap, the suture can go superciliary, or it can go, even I've had it go into the vitreous, believe it or not. But at least with the light, I can see where this is, and it is in the canal. And you can generally get around 300 degrees with this eye track device. But the main thing to really pay attention to is the hyphema management. We used to, after GAT, leave viscoelastic in the eye. And the next day, I would still have patients with large hyphemas, even though we left viscoelastic in the eye to raise the pressure. What was happening, though, is even though we injected viscoelastic, this is the same day, just hours after surgery, the pressure wasn't really elevated yet. And so the blood would still come back into the anterior chamber. And when you saw them the next day in the office, their hyphema was actually mixed with viscoelastic. So then we started raising the pressure. So at the end of the surgery, get as much of the blood out as you can and hydrate the incisions to raise the pressure in the eye to around 25, even 30. and stop their medications and slowly let the pressure come back down. And that's how we started limiting the hyphemas. The other way is also just treat 200 degrees instead of 360. But the steroids, I really have learned a lot from trauma, taking care of trauma and traumatic hyphemas, as well as angle procedures. But if the layered hyphema, once it resolves, even if you see the cells, the red blood cells, the microhyphema, start tapering the steroids. The steroids are there to prevent fibrin formation and scar tissue formation. But what happens is people leave patients on steroids for too long. And when they're on steroids for a long time, yes, you can get steroid response, but it also prevents the body from absorbing the red blood cells. So allow a little bit of inflammation to come in to remove the remaining red blood cells. But if I see a layered hyphema, I do treat with steroids 4 times a day, 6 times a day, because that can lead to scarring. Once the layered hyphema goes, we start to taper the steroids pretty quickly. If you do get pressure spikes, pilocarpine can actually be very good after angle procedures to lower the pressure pretty dramatically. So that's one medicine to consider. And I think when you see a lot of blood reflux, I stop the glaucoma drops that day after surgery. And then the next day we check the pressure. If it's maybe around 20, add a class back. If it's around 10, hold, don't do anything until you see them the next week. So trypan blue is actually a great way to identify trabecular meshwork. So we inject trypan blue because this patient, and I in my chart will write the pigmentation level. If it's minimal pigmentation, I will put in the note to use trypan so I can see the trabecular meshwork. If it's heavy pigmentation, I don't need to use trypan. But when you start, this is a very nice way to identify the trabecular meshwork. So that trypan that's in there, once we put the gonioprism down, you'll see that it really has a nice blue stain. Nothing else in the angle takes up trypan. So it's not going to be the ciliary body. That's why it's a very nice dye to use, but you have to make sure you put enough of the trypan in the eye and make sure it goes to the peripheral part of the eye, to the angle, so that you can actually stain the trabecular meshwork. But it's a great way to get a good view of the trabecular meshwork. And when you start doing angle procedures, I actually tell people to start using trypan from the beginning. Look at this view. This view is not turned enough away from us. So we're doing a KDB goniotomy, but we can't see the trabecular meshwork. The most common complication that people have with this type of view is they end up hitting the back part of the ciliary body band, and you can create a cyclodialysis cleft. So don't do goniotomy when you have this type of view. It's not a good view. You're not very confident what you're treating. So generally have the patient look away from you more, turn the head more, because that is not a great view. That can lead to danger. This is also not a good view, but for a different reason. We're on FOSS. We see the trabecular meshwork, but look at the striations in the cornea. You see these? It starts to obscure the view. There's 2 main reasons that happens. One, we're pushing too hard with the gonioprism, so that makes the striae. The other thing is we're pushing too hard with our device, and we're hitting the back wall. And in fact, in this case, this is pushing too hard. Look at how the tissue is bent and distorted because they're pushing against the back wall of Schlemm's canal. That creates the striations in the cornea. You do not need to push that hard. Once you're inside trabecular meshwork, you're almost scooping the trabecular meshwork towards you. Do not push hard. That damages your view, and it actually can potentially even damage the collector channels. So I really want to summarize, then we can take questions and have discussion. But the infranasal angle really is probably the best area that has the most number of collector channels. So just working nasally is already going to give you an advantage. And infranasal tends to be a little bit better. And I think now, between the data that we have from pathology and also results of GAT, treating 200 degrees probably gives you as much efficacy as that you will get compared to 360 degrees. And 360 degrees might just give you more bleeding. But thank you so much. And we can definitely take questions in the chat. Vanessa, if you can help me, or take any questions that people have about angle procedures.
Thank you, Arsham. So let me see. I think the chat comments were when you were sharing, but we couldn't see it on our end. I
Okay.
don't see any questions so far.
Here's one. Okay. So among angle-based MIGS, Cahook, GAT, iStent, iTrack, Hydrus, which one do you consider to offer the best cost-benefit ratio? It's hard to really say that. I mean, I would say that almost all of these, honestly, if you studied them in 1,000 patients in each group, they'll probably be very similar results. And so if you're asking cost effectiveness, it's how much all of these things would cost in your country or your surgery center. But in general, they probably will offer very similar IOP reductions. The data for Hydrus, at least, and maybe the other ones, if we study them, we would have the same results. But the data for Hydrus at least shows less additional glaucoma surgeries, and it prevents or reduces the rate of visual field loss over 5 years. So data-wise, Hydrus might even show that it prevents vision loss. So that's why it's hard to say like what's cost effective, because what does it cost to prevent vision loss? And Hydrus actually has data behind that. What are your expectations, long-term results of MIGS surgery? So I really consider MIGS or angle procedures as being successful if the pressure is somewhere in the mid-teens, even with 1 or 2 medication classes. And I really believe that a surgical pressure, even if it's the same average pressure, is probably better than a medicated pressure that can have fluctuations. And that's why the light study is so interesting, because the average pressures at 6 years were very close between the medicine arm and the laser arm. But the laser arm had less trabeculectomies and less visual field progression than the medication arm. So even if the numbers are the same, that doesn't bother me. What I'm looking for is IOP stability and less fluctuations. So another comment, we know that phacoemulsification reduces IOP in patients with glaucoma. What reason do you think most MIGS surgery studies are performed in combination with phacoemulsification? That in the US is really a recruitment issue, is to get practices that are going to recruit enough patients fast enough for you to actually study a procedure. You have to get cataract surgeons involved. They do more volume than just a standard glaucoma surgeon. So that's one. The second thing is there is an added benefit of angle procedures with cataract surgery. We do them standalone as well, but certainly phacoemulsification helps. But look at the Hydrus data. Hydrus data showed phacoemulsification versus phacoemulsification with Hydrus. The average IOP reduction was only 2 millimeters of mercury at the end of the study. So it's not very big between the two groups. But even those 2 millimeters of mercury, because phaco lowered IOP, but the Hydrus group had less secondary surgeries and less visual field progression. And so, yes, part of the reason why they combine them is for efficacy, but also for patient recruitment. Do you think the intention is to enhance its results? So yeah, that's kind of what we talked about. But that's why if you look at MIGS studies, especially if it's something that's new that you haven't seen, you really need a control arm that's cataract surgery alone, because cataract surgery certainly can lower IOP. It probably doesn't last as long as when you do something in the angle, but that's something that also people can debate. In what cases do you perform standalone MIGS surgery, and how frequently is it performed in your practice? I really prefer standalone procedures in young patients. So patients that are not medicated for years and years, and also secondary open angle glaucomas. So post-traumatic sometimes, especially early enough. If they've been treated for 10 years for drops, it might not work as well. Uveitic, steroid responders that are on chronic steroids, those are the patients that I think probably benefit more from standalone. The longer they've been treated with medications, I find the less likely the angle is going to work. And I don't worry so much, like we were saying, about disease severity. I worry more about how long they've been treated with eye drops that are toxic to the eye. One of the characteristics initially defined MIGS surgery was the absence of a filtering bleb. Where would that leave surgery with Zen and PreserFlow devices? They are now called MIBs. Is this another category? I mean, I think this is more semantics. Is it MIGS or not? I find things like Zen to be a blend of everything. It's like a hybrid surgery for me. It's a blend between trabeculectomy and tube shunt. It's a blend between MIGS and subconch filtration. It is low invasiveness, but it still creates a filter. It doesn't rely on the trabecular meshwork or the outflow channels. I wouldn't worry so much about what they're called. People are going to call them all sorts of different things. More in your mind should be, when do you do that type of procedure? And I think where Zen really shines, and PreserFlow, we don't have as much experience in the US because we're waiting for approval, but Zen really can shine in patients that are at risk for hypotony. And again, I am very comfortable with the pressure going from even 18-19 to 14-15 if it's a surgical IOP reduction. So people that need something in the mid-teens, Zen can be really good. The technique matters. You have to be careful to remove tenons away from the device, whether you needle it at the time of placement or you take the conjunctiva down. But this is different than angle procedures that are more physiologic. If I was really thinking about it, Zen to me is still not a MIGS procedure, but it has the safety profile that is much better than our traditional subconch filtration procedures. In general, what is your current management plan for patients with glaucoma? If they are going in for glaucoma surgery, then my glaucoma procedure will be more aggressive. If they are going in for cataract surgery, but they have glaucoma, then my glaucoma procedure will be less aggressive. So it's, why am I doing the surgery? And I think in today's day and age, if a patient, even if they're controlled, is on medications and they're controlled with stable disease and they have cataract, you should at least talk to them about angle procedures. I'm not saying everyone has to have a MIGS, but they need to know that there are procedures that can lower their IOP and reduce their drops better than just straight cataract surgery alone. So thank you, Jorge. So have you ever used the ocular Ahmed DVX surgical gonio lens? Makes a direct gonioscopy. No need to move the patient's head or the microscope. I have. Actually, the optics are amazing. It really can keep you from having to turn the head. I think that's a personal preference thing. There are gonio prisms that are also called hands-free. They can be easily manipulated. Whatever works for you is best. Some people don't like the head turn because they feel like they have to really lift their hand to work. Some people like the head turn because it makes them easier to do the device. So I would say try whichever one you think, but I think they're both fantastic. So what type of gonio lens do you recommend? I actually use disposable gonio lenses from Corza. I don't have any financial interest in them. The hands-free version of that I helped design with them. It's more for teaching. There are some people that really like it. I prefer having the handle, but Corza makes the gonio prism that's disposable. The view is always good. The hands-free, you can rest it on there and use two hands to stabilize as you're doing it, but it still tends to move. And so you can take your finger and nudge it back into place as you're working with it. But there are some people that really like the hands-free. Can we compare the GAT 200 degrees to KDB results? So as far as going like suture GAT versus KDB, there are a few small studies. I think if you're looking as a standalone, in general, 200 degrees will probably beat 100 to 120 degrees. And so if you do KDB for 200 degrees, I think you should have very similar results as if you did GAT for 200 degrees. So it's not the procedure itself. I think KDB goniotomy can work very, very well. It's how many degrees are you treating? That's more what you should be thinking about. And Vanessa, I think that's all the questions that came up.
Let me ask you an additional question, a follow-up on
Yes.
that, because I love, and every time I hear to your talks, I learn something new, Arsham, and I think I hear you every month, literally, and you
Crazy.
always
No,
come up
no,
with
that's
something. I
not
love
true.
it. So you said the study that talked about that after 6 clock hours or 180, basically there's a floor effect or the same effect, or you shouldn't get a better effect. So to that same point of the KDB, 120 or whatever is, maybe you can make it to 180. What's the benefit of going with GAD for 200 versus just 180?
Yeah, the 200 actually comes from clinical data where the around 180 to 200 seems to be where it plateaus. But 200 on a couple of smaller studies seem to have better IOP lowering than just 180 alone. Beyond that, didn't seem to show much of a difference. And the basis for that is early outflow facility studies. When they removed trabecular meshwork for 6 clock hours or 180 degrees, the outflow facility was the same as if they removed 360 degrees. And we knew that. Then clinically, we were like, it doesn't matter. I'm sure 360 is going to be better. But then you start doing 360 and now looking at your data, and it doesn't seem to have better IOP reduction. But you're right. Even KDB, it can perform very similar to 200-degree GAT. You just need to do it. Sometimes you have to move your body or your scope to do more removal.
Okay, thank you. There's another question in the chat.
Yes. So, do you find an angle procedure after SLT will be more difficult to perform? I do not think it's more difficult. And the question is, does the response to SLT tell you something about how they will respond to MIGS surgeries? I don't think so. I thought we could. We looked at our own data. We didn't really find a correlation. But doing SLT before, I haven't noticed any difference. A lot of our patients get SLT before angle procedures, and we have not noticed a difference. There's not more scar tissue. And SLT generally should not cause really high PAS. So I think even if you do it, SLT, it doesn't change how you do the angle procedure. The results and efficacy, I don't think it makes a difference either, but some people would argue that.
Okay, I have another question. I want to go deeper. You already touched a little base on that, Arsham, but in our group chat, we have a lot of discussions and a lot of participation, I'm going to say, every time we talk about phaco alone for glaucoma patients versus phaco something else. And it is true, and you have acknowledged this publicly, that there is a reimbursement, there is a money incentive in the US to use some of the canal procedures. So what I think the Hydra study, you summarized it pretty well, that is one of the strongest studies that we have nowadays to show 5-year data, the need for secondary surgical interventions, the visual field stability in the long term. But there's still a lot of people who are hesitant and feel that phaco alone is good enough, I'm going to say, for our patients. So can you go a little bit over that? You touch again base a little bit, just a deeper thought into the why or the why not.
Yes, I think that's a great discussion actually, because phaco, if you look at the OATS study, phaco in those patients really did well for IOP reduction for years. But again, it's not comparative to phaco plus an angle procedure. And when you look at studies that compare phaco versus phaco plus an angle procedure, both groups lower pressure. But almost universally, the phaco plus the TM procedure lower pressure more, have better drop reduction. And for me, if I am going to commit a patient to taking eye drops, even if it's one class, I feel that their disease is bad enough to take medication. Well, the medication also has issues, from cost to the psychiatric component of remembering this all the time. If I'm committing them to medicine and I have data that tells me that phaco plus an angle procedure is better than phaco alone from an IOP perspective, with really good safety between the two, why would I not do an angle procedure? Because I have a better chance of drop reduction and a better chance of IOP stability for a little longer. And I don't think that every phaco surgeon has to do MIGS surgeries, but I do think you need to talk to the patient that there are options at the time of phaco that can help reduce their pressure a little bit more than cataract alone. And as a doctor, you can say, I don't really believe in that. We're only going to do the cataract, but at least you and the patient should have the discussion. But the data will tell you that it's still better to do the angle procedure from an IOP perspective and reducing medications.
Thank you. One more question.
Thank you. What do you expect between SLT plus phaco and MIGS phaco combination? You know, SLT phaco, it's not like a common thing that people do. There are lasers in development that are femto based and some that are excimer based that maybe could enhance when you do it with phaco. SLT plus phaco, I couldn't tell you if there's any like advantage there. I would imagine that an incisional angle procedure like MIGS, stenting, or goniotomy will probably perform better than SLT. There's not like randomized studies to say that, but you can see it clinically. We will have patients that we do SLT on, don't get much of a response, and we go in, and when you do like a MIGS procedure, sometimes standalone, like in steroid response or uveitic, the MIGS procedure lowers the pressure more. It also has a little bit more risk of bleeding, but I think there's, to me, pretty obvious reasons why an angle procedure getting past the trabecular meshwork should do better than SLT.
Okay. One more. Sorry, I'm asking a lot of questions.
No, it's
but
great.
I love picking your brain.
No, this is great.
The bending of your needle. So I love, and that's something I heard, but I don't really understand. And maybe you know some science behind it, to try to have that elbow that you're trying to make with your second bend, or to try to not touch the collector wall. What is the rationale for that? Is it real, or is it theoretical that
it's more it slides easier? Like if you have a sharp angle like this, sometimes the needle can catch against the back wall, but if you have this kind of second bend, it almost has like a curved space behind it, so it slides easier. But really what you should be doing is once you enter the trabecular meshwork, you should pull slightly toward you, just a little bit, so you're not pushing against the back wall, because that's where you can cause striae and even like damage the collectors. But it's more a preference thing for me, just having a little curve behind it.
And is that quote unquote damaging the collectors? Is there evidence to support that, or is a gut feeling?
No, I don't think so. I mean, there are histopathology slides that show that goniotomy can cause scar tissue formation in the collector channels, but I don't know why that's happening. If it's just doing the goniotomy or if it's pushing against the back wall, I think that's really probably hard to tell.
Okay, thanks.
Yeah.
Another question there.
Dr. Gerhard is in the chat, might have tips on bang. So if they want to...
If they want to chime in, maybe we have somebody who has done a lot of bangs.
Bang, yeah. Andre Gerhard. But yeah, if they're available, they can definitely speak up.
There you go.
Hello.
Hi. Any tips?
Hi. I do bang, but I look what you do. It's for me an inspiration. So I don't know if I do something different. I'm a very bang. I do a lot of bang. I very fan of it, but I think I do the same as you. I look at your paper, so I do the same. Nothing more.
And that's the nice thing about it. I mean, it's so simple. It's almost silly in some ways. But we are putting together like a pretty large case series between a site in Canada and our site. So we'll publish those results soon of just the results of the goniotomy. But I do think for cost effectiveness, it really can be very cost effective. There's a question here on the laser procedure. Here, let me see here. The helio laser procedure. Do you have experience with the helio laser procedure? I do not have experience with the helio laser procedure, actually. Not in the US.
Not yet.
Not yet.
Okay. So we're on the top of the hour. Yeah, okay, thanks. So I think I'm gonna say on behalf of the Venezuelan Glaucoma Society, thank you so much, Arsham. As you can see, there was a lot of interested. Everybody's always, even though our country is not letting us, we're not stopping. We're Venezuelans and we're gonna continue and find a way to stay on top of the latest and greatest and fight for it. So we really appreciate your time. And you did speak slow, so thank you for that. And your videos were so self-explanatory. It was awesome. Thank you so much.
Thank you so much, Vanessa. I always love being involved with whatever you do. But thank you, all of you. Thank you for your time tonight. It's very, very nice of you to have me do this. I really appreciate it.
Thank you, Dr. Arsham. It has been an excellent presentation, a lecture, and valuable overview of how to get started in the world of MIGS in a clear, detailed manner. The doctor, you share with us key insights and to those who wish to begin into the journey to MIGS, into the MIGS journey. Doctor, it's been a pleasure and an honor to have you in our meeting space. I want to thank you for your time and your brilliant presentation, and to extend once again your permanent invitation to the Venezuelan Glaucoma Group in the future.
Thank
Have a
you.
good. Thank you again, Doctor.
Thank you. Good night.
Thank
All right. Bye, Vanessa.
Bye. Thank you.
Bye. I'll see you. Thank you.
Bye.
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 Bye, Andres. Bye.
Gracias, Vanessa. Gracias.
A la orden. Espero que les haya gustado y que les haya sido de...
Aló. Aló.
Aló. Me
Se
escucho.
cortó.
Tanto en
Cortó.
contactar por...
Que espero
por
que les
tu,
haya sido útil. A mí me parece que él habla espectacular. Es un profesor innato ese niño.
Sí, sí, sí. Sin duda alguna.
Sí, señor.
Espectacular, de verdad.
Habla de una manera sencilla, habla de una manera muy simple y con mucha pedagogía, de una manera sin complicarse mucho, ¿no? Y transmite mucho la atención. Quiero darte las gracias a ti y a Michele, siempre dispuesto a ayudarme, y a ti, Vanessa, por tu colaboración en contactar al doctor Arsham, y bueno, por tu participación como moderadora en la sesión y en la parte de las preguntas.
No, las preguntas...
Bueno, vamos
Vanessa, no te olvides que tienes tu charla en el Congreso, ¿no? De actualización de tecnología. Don't forget that.
Tienes que recordarme cuando te la tengo que mandar, pero le iba a decir...
Jesús.
Por las
You have to keep
preguntas
track.
estuvieron espectaculares, la participación de todo el mundo y la perfección como escribieron en inglés me dejó impresionada. Felicidades a todos.
Bien, gracias.
Excelente, Vanessa. Bueno, Vanessa, sabes que ya comenzamos ahora la fase de más en inglés en los web meeting. Y bueno, vamos a contar con tu presencia. Te vamos a estar molestando muchas veces para que colabores con nosotros en los
Claro que
invitados
sí.
internacionales.
Ok.
Gracias a todos.
Buenas noches.
Chao.
Gracias, y buenas noches. Y bueno, nos vemos en una próxima oportunidad.
Gracias, Jesús. Hasta luego.